I mean, no one going through this is going to get better. I don't care who you are, right? And so that means the rest of us have to change. And the good news is, and I discovered this, when you have resources, it's actually easier to change. And so we need to change our approach to the population. And I think a lot of that means giving them the things that they need to be healthy.
Well, good evening, everybody, and welcome. I want to welcome you to our first ever, our inaugural distinguished lecture in community engaged research. And in a minute, I'll be introducing our distinguished alum, Ricky Bluthenthal. But what I need to say is welcome to everybody on Zoom. If you guys would join me in silencing your phone, just for about an hour, you can put it back on in a couple seconds. I want to thank our co-sponsors as well. I want to thank the School of Social Welfare. That's where I'm a professor. My name is Kurt Organista, professor of social welfare and current director of the SSI. Also, the Department of Public Health. The school, excuse me, of Public Health, the Department of Sociology. And also the Berkeley Center, or I should say ISSI's very own Berkeley Center for Social Medicine, for the study of social medicine. For those of you who don't know too much about the ISSI, that's peculiar because it's been around for 50 years. But as you can see here, this is UC Berkeley's home for 50 years for interdisciplinary transformative social change research. And in our ecosystem, there are 8 embedded centers. You can see there's the Asian American Research Center, Latinx Research Center, Joseph Myers Center for Native American Issues, all centers that are very much aligned with the mission of ISSI, which began as the mission to understand the social stratification of race and how to mitigate that social stratification. So we're going to take just a couple of minutes and see a quick video about some of our past alums, people who have come through the graduate fellows program, and then we will continue.
I think it was a turning point in my graduate career here, and I really am indebted to the program, and I love the family that it's given me.
My life, when I was a fellow here at the center, the first day of my first seminar was the day that my daughter was born. So she turns 10 this summer, so I can't get my head around the fact that was almost 10 years ago. It feels like yesterday, it really does. And having the opportunity to work here at the center was so helpful in so many ways, just from the simplicity of getting out of the home from nursing a child to have rigorous academic, intellectual, social change conversations on every Wednesday night was literally just essential. I needed it. So it was really great. It also enabled me to go out in the field and do the research that culminated in this book with my daughter at my side. With the extra resources and the support of the center. She came along with an indigenous Mixteca ex-farm worker woman who took my daughter along with me, and we did interviews together.
The space was one of the only places on this campus where I really felt like my ideas were understood, acknowledged, and really manifested especially through the work of Christine, David, and Deborah. They were incredible mentors to me when what was then the Institute for the Study of Social Change. So I want to thank the 3 of you very, very much, because I literally wrote the first page of this book here. And it's amazing to be able to see it materialize.
It's such a warm space for me, given that ISSI was sort of instrumental to my progression through graduate school. So again, just a pleasure to be here.
being a part of the scholarly community here at ISSI really did shape so much of this book and so much of the trajectory of my scholarship more broadly. So I say I've been especially thankful to be a part of scholarly groups that have critically shaped how I think and write about issues of social justice. A special thanks goes to the Institute for the Study of Societal Issues at Berkeley, which provided not only financial support, but an intellectual home for a lonely social change scholar. Thanks especially to Christine, David, and Deborah for caring about the whole me and for the insightful and close reads of my work and for being some of my best critics and cheerleaders.
This center was very instrumental in providing support for completing my dissertation, and it continued to provide support when I was working on the book. So it's a great space, and this university is very fortunate to have this space.
I'm also a former ISSI fellow. I'm proud to be one. I remember, I was remarking, I remember, let me bring my PowerPoint up here. I remember being a fellow and having folks come back to the center. And I can remember Christine and Deborah and David welcoming folks and people just, remarking how impactful it was for their career. And me thinking, wonderful to be impactful for my career. I was kind of feeling it, and it definitely was. And I'm happy to now be here and similarly say, wow, thank you so much.
The ISSI was a very important part of my academic growth and academic journey. And the book that I'm going to be talking to you about today would not have been possible without my affiliation with the ISSI. I was a graduate fellow at the ISSI. I had an office in the ISSI building. I attended many talks, met many faculty and students. And so I feel like besides Barrows Hall, which is where the sociology department is, the ISSI really was where I learn to become a sociologist, an academic, a researcher.
A lonely social change scholar. How many of you in this room, as students or as academic professors, teachers, how many of you have known that feeling? I've certainly known that feeling. Was the first Latino professor of social welfare, starting way back in 1990, and trying to study Latino psychosocial and health problems. And so gratifying that the ISSI can be a home, can be a hub for professors like myself, for lecturers, for staff, for graduate students. Really the centerpiece of the ISSI, as so many of you know, is the Graduate Fellows Program. And you just heard from quite a few. Just very real, very genuine people doing social change research. We set a very ambitious goal. This is our 50th anniversary, as I mentioned earlier. We set a very ambitious goal of trying to raise $200,000 this year. I was like, hey, why not $1 million? But a couple people in the audience said, let's bring it down. Let's be a little bit more pragmatic. We have been actually making a very deliberate effort to do fundraising. I would like to say that that's kind of new for the ISSI. But I want to thank Charles Briggs over here, who was our outgoing director, who was our interim director back in the spring. You can say hi, you can wait. And I also want to thank Deborah Lustig, our associate director, who all of you know. They really made a deliberate effort back in late spring, early July when I came aboard. They were saying we need to do fundraising. We have economic austerity, as so many of you know, in the state of California, and also on the UC Berkeley campus. So they started that. I was happy to participate. And I don't know how impressed you are with having raised $76,000 to date this year, but I think that's a personal best for the ISSI. And we do it for all the reasons that the ISSI stands for. And so we will continue. We do have one of those QR codes that you're welcome to pull up on your cell phone. I think I told you to silence it, right? But you can unsilence it just for this. again, to support our mission, the work that we do, we would appreciate any continuing donations, any new donations of any size, really. But speaking of size, our efforts have been so deliberate that we actually came up with a little bit of swag here, as you can see. We have not just a sticker, but a limited edition sticker for anybody giving over $25, and a mug, and that's like a 2-cup mug, the kind academics need in the morning. For anybody giving over $75, we actually have some of those on the table as donations rolled in this evening. I'm going to introduce our guest speaker today, our distinguished alum, Ricky Bluthenthal. And I want to go over his title here very carefully because it means a lot in academia. It certainly means a lot to me when I see titles like this. First of all, he is a distinguished professor and chair of population and public health sciences at the Keck School of Medicine, University of Southern California. You know, distinguished is it's one of the most vaulted titles that you can earn in academia. It's really doing nationally impactful, internationally impactful research at the highest level. It's not a title that's thrown around lightly. And he's also, as you can see there, not just a distinguished professor, but the chair of population and public health sciences at the Keck School of Medicine. And not surprisingly, he has an endowed chair. It's the Flora L. Thornton Chair in Preventive Medicine, I believe. So these are amazing titles. If you saw his resume, it's extremely impressive. He's got over 225 peer-reviewed research article publications, quite an accomplishment. And he's here today to share with us some of his community-based research. Maybe share a little bit about your role here as a graduate student when you earned your doctorate and master's here in the Department of Sociology. And he was a scholar activist, the way many folks who come through ISSI are. And I love this title. I really want you to look at that title, Centering the Disadvantaged, Reflections on Community Partnerships and Solidarity Research with People Who Use Drugs. That's a phenomenal title, if you really think about it. It's not the conventional way that our country thinks about alcohol or substance abuse and those kinds of problems and interventions. This is really about, I was really keying on solidarity research with people that use drugs. Drugs are a ubiquitous part of our culture. Friends, family, ourselves, neighbors, and we should be in solidarity with this social problem. So I'm going to welcome you to the podium now. And
let me just say before I get started, it's an amazing honor to be asked to speak on this occasion for this institute, which has been so important. And it's interesting. As I told someone in passing earlier, I really didn't have a good time in graduate school, but having endured it, I've had a great life ever since. So 10 years of suffering, 30 years of success. I think we must take that. The other thing I want to say is, ISSI, or as it was previously the Institute for Study of Social Change, had actually been in my life longer than I knew. So I was an undergraduate student at UC Santa Cruz, and there was a couple of fellows of the Institute who were Santa Cruz professors. So Hardy Fry, David Wellman, I want to say Deborah Wong. Woo, thank you. I knew I was getting that wrong. And so they had been sort of grooming me to come here. So much so that when I applied to graduate school, Berkeley was the only school I applied to because I'm also painfully naive. But it ended up working out. And so, in fact, my first year, I got support from the Institute. And that's when I wrote my Ford Foundation application, and then I got that fellowship, and so then I was off and running. So really instrumental. But more importantly, like I said, I spent a lot of time in Hardy Fry's office in Santa Cruz, and he spent a lot of time getting me ready, and emphasizing something that I say to my students now, which is that at the end of the day, the world gets better because we make it better, and to make it better, you have to be at the table, right? You've gotta get the things that then allow you to have an influence. So I'm eternally grateful to ISSI, or as it previously was called, the Institute for Study of Social Change, and I'm really glad I went to Berkeley. Okay, like I said, it really worked out. Okay, so these are just my funding disclosures. I do also have a couple of longstanding current and former and ongoing colleagues in the room and some online. So Alex Sprawl, Kelly Knight, Barrett Landon, and then Anthony DeMario, who've all contributed to my learning and picked me up when I was down. And hopefully I did the same to them. So when I talk about this, I hope you see that, throughout all of this stuff is a lot of relationship building and learning that we do together in community. And that's a big deal for me because I'm an only child and I can really spend a lot of time alone. So thank you all for putting up with my weirdness. All right, so I'm a sociologist. I've been doing more or less the same kind of work for over 30 years. I did one of the first HIV epidemiological studies of people who inject drugs in the Bay Area. So John Waters, our former sort of mentor who started the research in San Francisco with funding from the CDC, got money from NIDA, and then invited a naive but confident young man to take over the study in the East Bay. And so that's what I did. So we did HIV epi studies in Oakland, and then in Richmond, and then in East Palo Alto. And I'll get into that story more. But that was, really formative work for me and set me up for a pretty productive career. We've looked at interventions, as was pointed out. I helped start and then run the Open Needle Exchange, which is still in operation, and is bigger and better than ever, as I told the current executive director. Another example of addition by subtraction. So it's an incredible program. Please give them money. And then I do most of my research is sort of this mixed method stuff, and I think that's really important. I mean, I'm always stunned by the confidence of quantitative reasoning. Like, so much about human behavior that you could just ask a couple questions and that's it. Like, you know what I mean? Like when you just deconstruct it a little bit, you're like, wait, that's what we're doing? Anyway, so I think it's helpful to really do qualitative research alongside quantitative research so you have an idea of actually what's happening. And then I already talked about this. Sorry. Okay, so this is the overview. So I'll talk about what it means. Oh, I can see it. Thank you. Centering disadvantage meant to me, and then take you through some of my travails in this work and successes, and then just have some concluding thoughts. One of the things that's nice for me is that because I've been doing this all so long, I feel like I'm in my distillation period. So I can really just share with you the highlights and the things that really, I think, at the end of the day, I think are meaningful. And I'll try and do that today. So I think the first thing is research humility. I mean, I already shared things that stun me. But, I just think it's really important to realize both why you're doing something and how while you're doing it probably doesn't matter to the people you're doing it with, right? And it's interesting. So I went to the first half of the symposiums, and I appreciated that people were very straightforward about like how they were invested in the topics, or that a parent, this or that. And that matters. I mean, every sociologist I've ever actually gotten to know has that same story, that sort of origin story about this thing happened and it motivated to me. And that's a great place to start. But it's also important to remember to not stop there. Because just because it's important to me doesn't mean it's important to someone else, right? And part of the challenge and the beauty of sociology is that at the end, if we're doing it right, we're really illuminating what the world looks like to someone else, right? We're understanding how the systems operate in their lives in a way that's probably different than our own. And I just hope we never lose that. But it's really essential. And it's one of the things that I run into all the time. I mean, I feel like I jokingly tell my wife I've done the same study for 35 years, which is not true. But there's some rhythm, rhythm in that, some rhyming in that. But the whole time I'm still learning. Like you would think you've done something for 35 years, you must know everything. It's like I'm learning new stuff all the time and appreciating things that I thought I knew, and then wait, but no, there's a deeper meaning to that. And so it's just a great opportunity. And one of the best things about getting a PhD for me has always been like, I get paid to learn, which is amazing, particularly in this economy. So I think that's important. The other thing is I take other people's lives seriously, right? And it's not merely that I don't want to like violate their, human subjects' rights. Like, their lives matter. And thankfully, and I'm not sure how I got this, but very early on in my career, because we were doing HIV work and because people were dying of HIV when we got started, right? This was 91, 90. We had to give out what essentially were death sentences in the study. And that wasn't cool. And that's real business, right? That's, and so recognizing both that what you were doing was helping someone, but also telling them really bad news that you couldn't do a lot about, also made me feel like, well, then I'm obliged to do something about it, because we do live in a society that has an incredible high tolerance of suffering for disadvantaged people. I mean, it's amazing to me. Like people can really, we can really put up with it. And I don't want to be one of those people who accepts that. Like we're a wealthy society. We can have a different outcome if we choose to have it. So I think that's important. Like these are real people's lives. Their lives are as important as your own, and to act like you know that in the research you do. And that's what I try to do. I've probably not succeeded all the time, but that's been something I've been working on and continue to work on the entire time. All right, so and this is an audience of sociology and anthropologists, so I don't really need to talk about this so much with you, but I think positionality is really important. Most of the people in my study have not been African American, although many have been. I'm African American. I'm well educated. I'm older now. I've been housed and owned a house forever. I was raised in a suburban area. Most of the folks in my studies are in urban areas. And then I did get arrested once for running a needle exchange program, but I got acquitted, right? So and I haven't had those I've had my troubles with the system, but they haven't been at that level. So that's the grounds for being humble and asking questions, because I have not walked that walk. I have not slept outside. I do not know what it's like to be in opiate withdrawals. I have not been sexually assaulted, right? All of the things that are very common to the people in my studies, I have no personal experience of that. And so I should not go into my interactions with them as if I had. And thankfully I didn't. And that's part of the reason why I've learned and hopefully why I've had some success. So, I think engaging with people directly, spending time with them. One of the great things about running a needle exchange is that I get to spend a ton of time with people who use drugs and befriend them, and them to get to know me and me to get to know them in a setting that wasn't formal and wasn't hierarchical necessarily. And there was great insights to be had from those informal connections and conversations. And it's really informed how I think about the issues we need to take on to sort of achieve some of the health outcomes we'd like. All right, so I'll just do this really quickly. Things really suck if you're a person who injects drugs. They're difficult if you're a person who uses drugs. What I've observed over the course of my career that's been fabulous, and things have been gone great for me. They've gone worse for the people that I study. So this is just a standard map of the 4 waves of the overdose crisis. It looks like the crisis is abating a little bit now, but that's just the overdose deaths are gone down, and it may be just an epidemiological reality. Like we've killed so many people that the susceptibles are sort of evaporating. There's also been changes in drug use in the population, so a lot have moved, particularly on the West Coast, away from injecting fentanyl and towards smoking fentanyl or just injecting heroin. And so those are actions that the population itself are taking to protect themselves, and it's important to acknowledge that. This is the hepatitis C crisis. So when I started doing this work, it was a single hump camel. Now it's a two hump camel. We've got an ongoing crisis of bacterial infections that people don't report on a lot, but if you ran a hospital, you'd know about it. And that's happening all over the country. And then we've had these outbreaks of HIV in these sort of novel settings. The latest was Bangor, Maine, and they happen at the intersection of sort of homelessness, drug use, and then sometimes sex work, sometimes other things. So the problems aren't going away, even though we've had great successes until recently at least getting some of the prevention programs to become more standard and better funded. And some of that is because we're not addressing underlying issues, right? So this is a couple of studies talking about both trends in homelessness, but then also the relationship of homelessness to HIV incidents and hepatitis C incidents. One of the things that happened, so I grew up in Los Angeles. I left. I was in the Bay Area a long time. I came back. And so I started doing these studies with Alex in 1998. So he would do the data in San Francisco. I would be down in Los Angeles. And one of the things that happened over the time, and I'll show you a slide about this in a second, is that homelessness really increased. And that was because of the political economy, right? Like the drug users didn't become more irresponsible, right? The economy changed. And we withdrew social support for these populations. If you remember the mid 90s and the Clinton Gingrich, repackaging of social welfare, like all of those things, removing substance use as qualifying condition for disability, all of these things take resources out of populations and it leads to their immiseration. So that's really what we're focused on now. But I'll tell you how I got there. So one of the things that it's been interesting to observe, and I sort of hinted at this at the very beginning, is I always wonder about my colleagues, like where do they get their confidence about like they have solutions for things? Like, I mean, it is kind of weird. Like, it's like, we're really certain about this thing. And so, having been a successful HIV researcher, I have and then doing this harm reduction work, I have a nice counterpoint. So I'll just give you that counterpoint. So one of the things that's happened, our approach has really been heavily biomedical to HIV. And it's been crazy successful as biomedical interventions, right? Like, when I started, HIV killed you. Full stop, right? HIV should not kill you now. I mean, Trump is showing us how that can happen again by withdrawing the treatments for that. But, we have effective treatments that are easy for people to take that will prevent you from dying from HIV. That was not the case in 91. We didn't even know what hepatitis C was, right? We now can test for it. We can now treat it efficiently, right? 8 weeks, 1 pill a day. Amazing. Pre-exposure prophylaxis for HIV, right? Take this thing. You don't have to take it every day, right? 4 out of 7, you're not going to get HIV. We now have long-acting injectables. Go every 3 months, every 6 months, low side effects. Amazing. The problem is we're really bad at getting that to the people who need it the most, right? So study after study has found that people who inject drugs and people who use drugs are interested in these medications and somehow never get it. They're great stuff in the Bay Area. So if anyone's getting hepatitis C treatment, it's probably the Bay Area. There's people doing really great work in that space, but still most people who inject drugs, most of whom have hepatitis C, will never get the treatment that's, 100% effective and easy to do. That just sort of continues to be the story, and it's because we're not dealing with the structural issues related to why people are getting sick. And then, of course, the groups within the group, right, the minoritized populations, the women are the ones who suffer the most, right? So they're least likely to get it. And then, in the HIV world, this is true for men who have sex with men as well. We're not doing what it takes to get the medications to the people who need it the most. Right. And, I would argue that's a choice. Like, we know that's the case. It's been the case for a long time. And we're just not doing what it takes to get it to people who need it. The other thing, and this is an old slide, but when I found it, I was so happy because it reinforced my intuition. And so what this just shows you from, before COVID, the key thing is just this little bullet in the bubble in the bottom. So we spend about almost three times as much money on research of HIV as we do on preventing HIV. I'm not sure we have that many research questions, right? Like there's something else going on there. And I bring it up because then, of course, I want research to be funded and research is important. But you know what? If you have a solution, let's just spend the money getting it to the people who need it, right? We'll evaluate it. We want to figure out what's the most effective way to do that. But we're not even really doing that, right? So there's a lot of work to do around reorganizing our thinking. The other thing is that the CDC and NIH spent billions of dollars creating over 300 evidence-based interventions that were complicated, involved people with lots of education, multiple sessions, didn't match the needs of the population that was at risk. And so they had this big compendium. It's gone now, but literally 300 evidence-based interventions, randomized controlled trials, and they took it down because no county, no city, no community that has people at risk could afford to implement those evidence-based interventions, right? Like a complete mismatch between what the communities could do and what we were learning about, right? So again, we still want to do research, but I want to highlight that there are ways to do this that are more effective and reach people. And in this case, it's talking to the people who have the problem. So I'm going to show you the things that I've learned from talking to people who use drugs and then doing what they tell me to do. I want to make that an important thing. I'm doing what they tell me to do. I'm doing what they tell me to do, right? Not me, right? I'm doing what they tell me to. So, the approach is harm reduction, client-centered, practical, non-punitive, and not judgmental. But, I've talked to literally tens of thousands of people who use drugs. I'm a former Catholic. They have plenty of shame without me talking to them about their drugs, right? They don't need Ricky to weigh in, okay? So, if you think about, and having parented, if you think about like what are effective ways of getting to get people to do things, like if you want them to do something, give them a resource to do it, right? And then odds are they'll do it, right? And that's sort of the lessons of harm reduction in terms of looking at, what are the things they're facing. So early on in my career, we started the needle exchange program. The police were doing their thing. And, people were telling me, hey, the police are getting in the way, right? And so this is even before the needle exchange, right? So we did these studies looking at the impact of drug paraphernalia laws on their risk profile. And we found, oh yeah, because police were arresting people and confiscating their syringes, they were ended up being more vulnerable to HIV. So we published that work. And hopefully some of this data was the reason why we've been able to roll back the drug paraphernalia laws. The other thing is, we were running a needle exchange program and, we kept getting arrested and the police kept moving us. But the thing that was really great about it, and in some ways beautiful, is that people kept coming. So this sort of middle study talks about, yeah, we got pushed around, but at the end of the day, people still showed up and it was still effective. So if you looked at, was it doing the thing that you wanted it to do, it was still succeeding. We then did these other studies, just establishing the fact that having these service programs was actually leading to reduction in HIV, risk behaviors at least. And then the study in the middle, this is my favorite study. So we came up with this measurement of syringe coverage, which is this idea of how many needles is the needle exchange giving you for a period of time and how many times you're injecting. The CDC guidance was you should have one needle for each injection. And so we just looked at that in deciles, right? And found, to our relief, that the more needles you gave people, the less likely they were to shred syringes, right? So that's sort of real empirical evidence of the proof of the concept. And then when you looked at the program capacity, if they had more generous policies, you had lower HIV risk for the participants, right? So harm reduction works. Listening to people who use drugs works. Giving them the thing they need to enable a better well-being works. And, we know that because it works in our lives too. But we don't want to apply that to people who use drugs or people who are people of color or poor people or women. And, that's why we end up with some of the health problems that we do have. And then this is the one on naloxone. So this is a little hard to read, but I'll just sort of break it down. So if you just split it in half, on the left is two time periods in Los Angeles, and on the right is 2 time periods in San Francisco. And the data is reporting on reported overdoses, witnessed overdoses, and then the last thing is someone used naloxone whether it was overdose. And then the 2 time periods are basically 2012, and the second period is like 2016, 2017. And the great thing you see is during these periods, we really ramped up naloxone distribution at the community level, right? And so even though overdoses were going up, the amount of appropriate response to naloxone went up even higher, right? And then San Francisco was high, and it just kept going up even higher. If we extended this out, it would be even higher. So again, what works? What's inexpensive? What's sustainable? Giving the resources to the people who use drugs and letting them do their thing, right? Empowering them to achieve well-being. And then this is some great work. I always tell Alex that I think the work he did on safer injection sites, safer consumption sites, is among his best work. He disagrees. He thinks it's this other stuff, but I think I'm right. And this is one thing that he did. So this isn't even my work, but I just think it's so important that we highlight it. Come into this place, use drugs, you're observed, there are services there. If something bad happens, there's someone who knows what to do, and you don't die, right? I mean, that solves the problem, right? And we make a choice not to do that. And it also solves a bunch of other problems. Like if people are using these settings, they're not getting HIV either, they're not spreading hepatitis C, they're less likely to get bacterial infections because it's a clean, well-lit place, they're less likely to have injection injuries, right? Like there are all these benefits, and then they get access to services. And we just don't want to do that for people. All right. So we've had great, there have been great successes. These successes have mostly come from the people who use drugs. So I like to tell a humbling story about naloxone distribution. So there's a guy, Dan Big, who's sort of the godfather of naloxone distribution in the United States, at least. And I knew Dan. He died of an overdose. And I remember in 1993 or 94, he came to a harm reduction meeting with a duffel bag full of naloxone. And it's like, hey, we should be giving this to people. And like dummy me, I'm like, wow, I mean, giving them medication? Like, are we allowed to do that? And, I was all squishy. And fortunately, Dan didn't listen to me. And, that's how we save lives, right? Is by letting people do the things that they know work. There's great work that was done in Vancouver and continues to be done by the Vandu Drug User Union. And they've really driven the response to HIV and overdose deaths in Vancouver for decades. And they just stand it up, right? So they've stood up the first safe consumption site, regardless of what's going on in the politics, and then the rest of us catch up to them. All right, so this is just some examples, again, of what the sort of IMIC insider approach to solving these problems are. And I think they have a great track record, essentially. All right, so we still have challenges in this, and I'll try and speed this up because I'm sure I'm running out of time. The social determinants of health is a big issue. I think we also need to, I'll just cut the chase on this one. I mean, we need to get more politically engaged. And so that's part of the reason why I use the term solidarity, because I think, we need to do more than just coalition build. Like we really do need to sort of find ways to be with people in these spaces in a way that help them stay safe and create pathways to well-being. And it's not going to happen if we don't do that. All right. So the model, the thing that we've been using, and I was turned on to this by Ben Hinwood, who's a homeless researcher at USC, this notion of ontological security. I somehow missed it in my readings as a doctoral student, but I got it now. So I'm really happy about this. And I love it because it's got strong face validity. And it's a thing that we all take for granted, right? So like, how are you healthy? You have material constancy, you have social trust, you have privacy, right? And you have routines of daily life that you can support yourself with, right? And we do not give that love to other people. So we began doing work, and so, again, this was inspired by one of Alex's students, Joey Chang. We began asking people questions about how often they were moved over the course of a 3 or 6 month period. So this is the first paper we did in Los Angeles and San Francisco. And, the take home is what you would expect, right? So displacing people a bunch means they're less healthy, right? So overdose risk goes up, syringe sharing goes up, drug treatment use engagement goes down. Like, it's awful, right? Like, it does all of the things that you don't want it to do. Jesse, one of my doctoral students, who's now assistant professor, former doctoral student, who's now assistant professor at UC San Diego, did ethnography, influenced by the ontological security framework, and you sort of find the things you would expect to find, right? People are demoralized, they have important paperwork thrown away, they lose pets, their social networks are disrupted, and then it ends up they're not getting better, right? And you're just grinding them down, right? And we do that every day. These policies are really popular with homeowners. They're really popular in political settings. They're devastating to the population that they're directed at, and they do not result in solutions. So one of the ways we looked at trying to establish that is look at a dose response, right? So in this, what you're seeing in the black is people who were displaced by the government, and then the grayish is like voluntary moves, and then the lighter color is no moves. And you see when people are being moved around, they're losing things they need. So medications, Suboxone, naloxone, a lot of naloxone gets thrown away by the police and sanitation officers. Identifications, like all the things that you need to get services, right? And then, we looked at these other outcomes. So overdose risk goes up, syringe sharing goes up, material comforts go down, right? So clothing, clean, getting clean, having restroom access, all of that goes away. And then you're more vulnerable to violence, right? And one thing I don't like to point out, but I want to point out, is the sexual violence directed at women and men who are sexual minorities in these circumstances is horrific. This is 9% were sexually assaulted in the last 3 months, right? Like, every kind of violation is happening in these populations, and we can't have the patience to figure out how to help them in a way that doesn't, destroy them, right? And so this is, you can't read this. It's more math stuff, right? I still haven't figured out like visual aids or PowerPoint. I'm doing okay with the clicking. Okay, so at the end of the day, the problems faced by these populations, have to do with social determinants of health, have to do with the political economy, and they're really outside of their individual scope, right? I mean, no one going through this is going to get better. I don't care who you are, right? And so that means the rest of us have to change. And the good news is, and I discovered this, when you have resources, it's actually easier to change. And so we need to change our approach to the population. And I think a lot of that means giving them the things that they need to be healthy, thinking about the challenges they're facing in a humane way, and then being patient, because when you beat up on someone for a long time, they're not going to change overnight. And a big part of that is focusing on the role of them. They have their own lives. If we give them the resources they need, they're going to be successful at getting better. And I know that because we know that from the other stuff, right? That's what's shown in needle exchange. That's what's shown in naloxone distribution, right? That's what's shown in safer consumption sites, right? So let's enable them to be healthy by giving them the resources that they need. And then the system change, we're looking at a bunch of rollback of really important things. So there was some loosening of methadone regulations. They want to pull that back now. One of the things that's been great about buprenorphine, which is another medication for opiate use disorder, is that anyone can give it out. Like, I mean, I can give it out, I can't. But, any doctor can prescribe it. And in fact, the scope of work for nurse practitioners and physician assistants also includes that now. So it's like the first time in 35 years that people could get treatment kind of on demand relatively easily if we can get the pharmacies to carry buprenorphine. And there's some, because I don't know, because we can't have nice things, the federal government is thinking about rolling back some of that stuff. So we need to resist that, right? Because it's not going to result in better things for people. It's going to be expensive, and it will kill people, and it doesn't have to. All right, in terms of research, I mean, I think this gets a little bit more challenging. If we think about statistics, which I don't know a lot about, but I play one on TV. The basic sense of most of the statistics we use is that there's independent observation, right? So that means that, like, I ask you a question and you answer it and you're by yourself and nothing else influences you. And of course, we know that's not true, right? And it's easy to measure things at the individual level. So we're really focused on those kinds of things because it's convenient for us. And I think the story is we need to talk about these systems a lot more, and how people are interacting with those systems, and then take them seriously. I mean, one of the things, if you spend any time working with people who use drugs, and you're trying to maybe facilitate them getting into drug treatment, they'll tell you all the bad things that happen to them in drug treatment, right? It's like people have, and we know most people go to treatment many times. And there's routine, because the group is stigmatized, because people think their accounts don't matter, they often do get treated poorly. And so you have to figure out how to overcome that as well. So, I mean, I think it's really important to take people seriously. And then when you're thinking about what are the things that are holding them back from the life they want for them, or what they might want for themselves, is like begin addressing those topics, right? Helping with family reunification, making sure they eat regularly, making sure there's a place for them to just be safe, right? I mean, a lot of the spaces when they've had these drug consumption sites or safe consumption sites, or you have drop-in centers, one of the things you see is people are hanging out there because it's safe to hang out there, and it isn't safe to be outside. So we need to meet them where they're at and sort of give them things that they actually need. And then once that happens, trust that they'll get to the other things that maybe we care about. All right, so let me just conclude. The health crises we've been slow to respond to them. They've been awful, and often not effective, except for the ones that come out of the population. And that, if we want practical, sustainable solutions, the answer of my career has been to just listen to the people. And so that's what I invite you to do in your careers, or to start doing if you don't already do it. I think you'll find great success. Let me just acknowledge a few people. I already talked about them, Alex and others and my students. And thank you for your attention.